The next speaker is going to be Dr. Patrick O'Gara, the president of the American College of Cardiology, and he's going to discuss a real challenge that you encounter in our daily practice, the challenge of patients with low flow, low gradient aortic stenosis. But before we start, Dr. O'Gara, I want to make two comments. One comment is that this session has become real routine in our meeting and has always been of very high academic standard. And we appreciate the effort that was made by all the guest speakers, and really thank you for coming. And the second comment is that I know you, Dr. O'Gara, for more than 25 years, and you also haven't changed a bit over these 25 years. So there must be something in Boston that keep you this way. So thanks, Dr. O'Gara, and please.
Thank you very much, Yossi, for those nice comments. So this morning, you heard a tour de force from Dr. Vahanian about what's new in valvular heart disease, and he did not discuss in detail this challenging group of patients with low flow, low gradient aortic stenosis with or without normal ejection fraction. I think that this is a new paradigm in our approach to patients with valvular heart disease. And I think that this is the group of patients for which the heart team is actually most important. These are complicated patients, and decision-making requires the input of a multidisciplinary panel. This is really the outline of my talk. On the left-hand side of the panel, you'll see a cartoon depiction of a typical patient with normal ejection fraction, normal flow, high gradient aortic stenosis. I don't think the management of these patients requires a heart team. We know that onset of symptoms equates with the need for surgical intervention, particularly in low-risk patients. We know that there's a small group of patients who develop left ventricular systolic dysfunction before onset of symptoms. They too should be referred for surgery. These patients are routinely cared for by cardiologists, referred to cardiac surgeons, and undergo life-saving intervention at the appropriate time in their natural history. But my remarks over the course of the next 18 minutes or so are really going to be focused on the other two categories of patients on this slide. In the middle are the classical patients, on the far right here, I should say, are the classic patients who have dilated hearts, low ejection fraction, and classical low flow, low gradient aortic stenosis, for which inotropic stimulation has become the diagnostic procedure of choice to determine if they have true aortic stenosis or a cardiomyopathic condition. And in the middle, we'll spend a little bit more time on a group of patients that were actually first reported only 7 years ago in 2007 from investigators in Quebec City in Canada, Philippe Pibereau in particular and his colleagues, who brought attention to a very substantial proportion of patients, typically older patients with hypertension, who have low mean gradient, despite which they have calculated low aortic valve areas and preserved systolic function. And I do think that they challenge us with respect to our daily decision making. At the onset of my talk, let me define what is meant by low flow, low gradient. Low flow is traditionally defined by a stroke volume index of less than 35, and low gradient is typically defined by a mean pressure gradient of less than 40. And I think if we can use those as our benchmark across countries and across studies, we will have a consistent database by which we can learn further about the best approach to these patients. This slide is familiar to everyone in the audience who has evaluated patients with low ejection fraction, low flow, low gradient aortic stenosis. The use of dobutamine provocation, which can take place in the echo lab, and it can take place certainly in the cardiac catheterization laboratory, and it's a mechanism by which flow is increased, gradients are remeasured, and the aortic valve area is recalculated. And generally speaking, patients will fall into one of three buckets, as shown here. Patients who normalize their cardiac output gradient exceeds the threshold of 40, valve area calculates into a severe range, and these patients are usually referred for surgery, compared to patients for whom the flow is normalized but the gradient remains low, and medical therapy is generally recommended. And then a very challenging group of patients who unfortunately fail to achieve any increase in flow despite inotropic stimulation. And I think that they present in ways that are difficult to predict. Some of these patients in some of our surgical centers have nevertheless been sponsored for surgical intervention with variable outcomes. In the evaluation of patients with low ejection fraction, low flow aortic stenosis, low-dose dobutamine stress testing in the United States is a Class 2A recommendation. We actually do have evidence for this particular recommendation, and that's a real distinct departure from the remainder of the guidelines, in which most of our evidence, as Dr. Vahanian pointed out this morning, is actually level C. But certainly low-dose dobutamine provocation in the setting of a calcified valve, reduced systolic opening, ejection fraction below normal at 50%, a calculated valve area of less than 1, and a velocity that is reduced below 4 meters per second, or a mean gradient that is less than 40. It is important, I think, first and foremost, to make the assessment as to whether or not there is inotropic or contractile reserve, and this might be better referred to as flow reserve, because this test actually does not assess inotropic function as much as it assesses a change in flow from baseline to some level following the infusion of dobutamine at maximally tolerated doses. And flow reserve is actually defined by an increase in the stroke volume that exceeds 20%. Flow reserve is a very important prognostic marker for survival and improved ejection fraction and functional capacity following surgery in these high-risk patients with low ejection fraction at rest, low gradient, and severe reductions in aortic valve area. This is the most important parameter to assess with dobutamine stress, either in the cath lab or in the echocardiography laboratory. And as you can see here on the left-hand side of the screen, I've provided this from my colleague, Dr. Pibereau in Quebec City. For those who have appropriate augmentation of gradient with a persistently reduced valve area below 1 centimeter squared, surgery and or TAVR is recommended. These constitute the group of patients with so-called true aortic valve stenosis. And compare those who have no flow reserve. In other words, they fail to achieve an increase in stroke volume of 20% or greater. There are those who increase flow, their mean gradients remain low, and their valve area calculates above a severe threshold. These are patients with pseudo-aortic stenosis for whom medical therapy is appropriate. And then a group of patients who have no flow reserve yet have truly severe aortic stenosis. Decision-making here is quite difficult. It is anticipated that TAVR will be applied to increasing numbers of patients who fail to demonstrate flow reserve yet have truly severe aortic stenosis by all other assessments. And in this regard, I would draw your attention to the increasing use of CT scanning of the heart to assess calcium scores in the region of the aortic valve, and in particular in the region of the aortic annulus, the so-called density function of calcium. And these investigators and others have demonstrated in, I think, a convincing way that aortic stenosis of a severe nature does translate into a CT Agatston score in the region of the aortic valve that exceeds 1,650. And I would recommend to you, in patients in whom you're not able to make these clean distinctions with respect to flow reserve, that you rely on calcium scoring in order to help provide an additional data point by which you might be able to make these difficult treatment recommendations. Here's an example in the cardiac cath lab of a patient who had, a patient who had flow reserve. As you can see here, a significant increase in the cardiac index from baseline of 1.4 to 2.5 liters per minute. Without an increase in heart rate, this would certainly equate with a significant increase in stroke volume. You see here the mean gradient more than doubled, and the calculated valve area remained within a severe range. This is a patient with true aortic stenosis for whom referral for valve replacement would be appropriate depending on other patient attributes. Now, I wanted to point out the value of aortic valve calcification and relate it to the indexed valve area. In this study, which is actually a multi-center study comprised of investigators from both Europe and the United States, particularly at Mayo Clinic, I want you to note the overlap in the degree of aortic valve calcification, particularly in men who have varying degrees of severity of aortic stenosis as defined by an indexed valve area. Data such as these underscore the utility of using aortic valve calcification as a cross-reference with respect to the indexed valve area and the assessment of stenosis severity. As I mentioned previously, it is extremely important to assess for contractile or flow reserve. You can see here the differences in surgical outcomes, operative 30-day mortality in patients who had flow reserve here in orange compared to those without flow reserve in red, and some of these early studies between 2002 and 2008 reported from multiple institutions. Our more recent experience with the surgical management of patients with low ejection fraction, low flow, low gradient aortic stenosis comes from our European colleagues, and here low ejection fraction, low flow, low gradient aortic stenosis was defined by an ejection fraction of less than 35, a mean pressure gradient less than 30, and a valve area that calculated into the severe range. You can see here that perioperative mortality rates in this study were approximately 16% over about 8 to 10 years of surgical experience and 5-year outcomes of about 50%. Compare this number to earlier numbers where perioperative mortality rates were as high as 25%. And in the latter phases of this particular multi-center study, perioperative outcomes were measured more in a range of about 10%. I do think that we are improving with respect to our patient selection. We're improving with surgical technique, perioperative care, and getting patients out of the hospital not only alive, but also with some degree of functional improvement. And these are some of the attributes that would predict a poor response to surgical intervention, including a very high Euro score, the presence of multivessel CAD, and very low mean pressure gradients, and again, the absence of flow reserve following dobutamine provocation. So with respect to the timing of intervention in these patients in whom decision-making is difficult, our valve guideline committee on which I participated stated that AVR would be reasonable in symptomatic patients with low ejection fraction, low flow, low gradient, severe aortic stenosis who have an appropriate flow reserve as documented on dobutamine stress echocardiography. And we left decision-making with respect to that group of patients who have truly severe aortic stenosis without flow reserve to individual judgment, did not feel that there was enough data to allow a recommendation for management of all patients of this type. Here's an example in the cath lab of a patient without flow reserve, gradient at rest 32, gradient following dobutamine provocation without change in cardiac output, no change in mean gradient, and no change in calculated valve area. One of the algorithms with respect to intervention might be summarized in this slide. Certainly there are patients who are considered high risk, who develop flow augmentation following dobutamine provocation with ejection fractions of greater than 35%, but who do not have coronary disease and who do have viable myocardium. I think typically these are the patients without that 20% increase in stroke volume for whom we would advise intervention, compared to patients who have very low gradients and cannot walk 300 feet in 6 minutes. These are some markers of those folks who do not have flow reserve for whom surgical intervention is ill-advised. This is the group again. Excuse me for this delay. If patients, the interesting thing I think about this group of patients without flow reserve or contractile reserve, if you can get your patients through an operation, it's interesting to note that in studies that have reported such outcomes, there is an improvement in symptoms, an improvement in ejection fraction, and a 90% 3-year survival. Unfortunately, perioperative mortality rates are still in the 15 to 20% range, but these are some indicators, perhaps, that can be utilized with respect to decision-making in that group of patients with no flow reserve who have truly severe aortic stenosis, as documented by other techniques. So let's spend the last 8 to 10 minutes or so on this group of patients who have normal ejection fractions and so-called paradoxical low-flow, low-gradient aortic stenosis. And this is the phenotype on the right-hand side of the slide. What is the phenotype? This is a small left ventricular chamber with exuberant hypertrophy and a restrictive physiology. This is a phenotype that includes diastolic dysfunction, impaired relaxation, reduced compliance, and a exuberant excess of interstitial myocardial fibrosis, the degree of which actually tracks with response to intervention. Now, how is it that we can actually describe a group of patients for whom ejection fraction is normal, a gradient appears to be relatively low, yet the valve area calculates into a severe range? I think there are basically 3 mechanisms that contribute to the definition of this category of patients. First, we should realize that the cutoff values of gradient and aortic valve area are quite imprecise. I'll show you on the slide that follows. Namely, secondly, that there is clearly an element of intrinsic myocardial dysfunction, and that we should consider these patients as having obstruction in series by virtue of the fact that at least 85% of them have systemic hypertension. Now, I referred previously to the discrepancy in these cutoff values for severe aortic stenosis as defined by a valve area of less than 1 centimeter squared and a mean gradient usually in the range of 40 millimeters of mercury as defined by these crossbars here. And as you can see here, there's quite a great degree of imprecision, and in most series, a valve area of 1 centimeter squared actually corresponds to a mean gradient more in the region of 30 to 35 than it does to a valve area of, to a gradient of 40. So I do think that there's some problems with our definition of severity. I would point out that in the PARTNER trial, in which patients were studied with severe aortic stenosis, they used cut points of 40 millimeters of mercury and 0.8 centimeters squared as their definition of severe aortic stenosis. Now, I mentioned before that there's an excess prevalence of fibrosis, and here is seen in a study using late gadolinium enhancement on cardiac magnetic resonance imaging. As you can see here on the top slide, are patients with aortic stenosis, and in this series, nearly 2/3 of them had mid-myocardial fibrosis, the presence of which was associated with reduced survival over 4 years of observation. It's also true that increasing degrees of fibrosis equate with decreasing functional outcomes after surgical intervention for obvious reasons. So the degree of fibrosis of which these patients have an exuberant amount does contribute to long-term outcomes. Myocardial fibrosis can also be ascertained by studying the relationship between the histologic degree of fibrosis by left ventricular biopsy as a function of mitral ring displacement or tissue Doppler imaging. And as you can see here, in patients who have relatively impaired diastolic relaxation in the closed circles in this part of the graph, the histologic presence of fibrosis was quite generous. The same is true if you look at the valvulo-arterial impedance, which is a measure of the obstruction in series. Those who had relatively little mitral ring displacement have an exuberant, or I should say, a markedly increased level of valvulo-arterial impedance. So in this group of patients, we have come to appreciate the combined contributions of both aortic stenosis and hypertension that contribute to an excess of afterload with neurohumeral activation that leads to hypertrophy, the degree of which may actually be out of proportion to that which you would have predicted on the basis of aortic stenosis itself. This leads to interstitial fibrosis, adverse remodeling, ventriculovascular coupling, which is assessed using the valvulo-arterial impedance equations. All of these patients develop diastolic dysfunction, impaired relaxation, stiffness, and reduced compliance that does lead to myocardial dysfunction. Certainly of a diastolic nature, but if you look at longitudinal shortening as a more sensitive indicator of systolic function, that too is impaired. Now let me give you an example of a typical patient with paradoxical low flow, low gradient aortic stenosis studied in the cardiac cath lab. This is a patient who was referred with a mean gradient, as you can see here, of less than 40, but a valve area that calculates into a severe range. At baseline, this person is quite hypertensive, with systolic aortic pressures exceeding 200 millimeters of mercury and a left ventricular or left atrial pressure here of 35 millimeters of mercury. Following exposure to nitroprusside, there's a marked decrease in left ventricular afterload, as exemplified on this slide, and a marked reduction in left ventricular end diastolic pressure. And in this patient, as well as in many others, when systemic arterial afterload can be controlled, there will be, in many patients, an improvement in stroke volume index and an increase in calculated aortic valve area to ranges that exceed the severe threshold. It's important to make this assessment because on a population-wide basis, patients who have paradoxical low flow have reduced survival compared to those who have normal flow. This was the original report of now 7 years. This has been duplicated by many other investigators over time. Surgical intervention in this particular group of patients appears to be, at least on the basis of observational data, an improvement over medical management alone. Here's a group of patients here in a propensity analysis on the right-hand side of the slide, showing that with AVR and CABG as an intervention compared to long-term medical management, that these patients did fare better with respect to survival over the course of about 10 years. It's important to make these observations because I think many of our patients with paradoxical low flow are typically not referred for surgical intervention because we as clinicians are confused or we're concerned about the discordant information that we receive. A loud heart murmur, a mean gradient that's relatively low, an ejection fraction that is a high, yet a valve area that is reduced. I think we have to be quite careful. This is most recent data from the Cleveland Clinic looking at the adverse outcome that is associated with low flow, low gradient aortic stenosis and normal ejection fraction in patients compared to those with normal flow, whether or not they undergo surgical intervention or they are managed medically. And lastly, then, our recommendation from the valve guideline is that we felt that aortic valve replacement would be reasonable in symptomatic patients with this paradoxical low flow, low gradient aortic stenosis if their clinical hemodynamic and anatomic data support valve obstruction as the most likely cause of symptoms, and chiefly after a point in time at which their systemic blood pressure is appropriately controlled. So, Dr. Rosenman, ladies and gentlemen, in summary, I would like to leave you with 3 comments that in patients with aortic stenosis, echocardiographic reports of severely reduced aortic valve areas despite relatively low mean pressure gradients are common. And I think if you were to look at our particular practices, the proportion of patients who fit into this category approaches 40%. This is not an unusual clinical conundrum. The need for verification of low flow, low gradient severe aortic stenosis is quite high. Additional diagnostic testing should be utilized, dobutamine stress echocardiography in one venue, and the use of cardiac CT to assess calcium scores in the region of the aortic valve in other patients. And lastly, this is the group of patients for which a heart team approach is most useful. Thank you very much for your attention.